Start about another minute. Give people who were in the previous session time to move over. Then we'll get started. So going to say good evening because as I look out the window, it's dark outside here in Israel. Can you just write where everyone's from here? Just put it in the chat or just shout out. Charlotte is North Carolina. Okay. Caldwell, Idaho. Montenegro. If anybody needs a translation, you can click over here as well. Well, South Africa, Brazil. Wonderful. It's nice to get the international taste. It's one of the things I like about these congresses. We are a small group, so I would really like if we could all open cameras. Okay, thank you. Okay, wonderful. Wonderful. Okay, very nice. Thank you. Thank you for doing that. Let's just, let me see gallery view so I can see everyone here. Okay, there we go. All right, so we'll get started. My name is Allan Friedman. I have a degree in social work, a PsyD from Graduate Theological Foundation. And I found myself drawn to this time. Well, we'll get started. Let's just jump right in. Okay, this is the clinical application of psychoeducation in logotherapy. That's going to be our topic. What we're going to do for the next 45 minutes, we're going to talk about what is psychoeducation, which for me until about 2-3 years ago, I wasn't aware of the term. We'll look at how it merges on a theoretical level with logotherapy, and I will bring cases, one from Frankl's writings and some from my own experience about how we can use psychoeducation in the clinic of logotherapy. Okay. I'll start with actually the last line. My personal history in this topic was because I was invited to join a pilot project here in Israel called Navigate. Navigate was formed based on the RAISE program in the United States to work with people who were suffering from a first-time psychosis between the ages of 20 and 35, I believe, or 39. And the program that they built, where the main focus of the program was to prevent a second psychotic event for the person. It's been a program that's been used worldwide and was gaining in familiarity. It was gaining in reputation, and they started the project in Israel about 2-3 years ago, where with the public clinic where I work in was part of that project. The problems I had with psychoeducation when I first heard the term, and here we'll start reading about psychoanalysts have generally avoided discussion of psychoeducational interventions in the context of psychotherapy, despite education being a component of many psychoanalytic techniques. In other words, people were using it, but you weren't allowed to say you were using it. This wariness stems from Freud's early concerns about interventions that could be deemed suggestion. Wait, am I teaching, or am I trying to inculcate them with some other ideas? And perhaps a misunderstanding of various aspects of neutrality. Am I educating, or am I forcing my values onto someone, including viewing psychoeducational comments as over-gratifying? They're asking a question and I'm automatically giving them what they want. No, that's not what we do in therapy. We ask questions, we lead them, we don't give them answers. And this is what I grew up with. This is the kind of psychodynamic theory that I worked with for 35 years as a social worker. That if people ask questions, we don't automatically give answers. That's not what we do, and we certainly don't offer information for free. It's one thing if I'm a social worker in certain social services where the services that I'm offering are not therapeutic or not psychotherapeutic, but they're in kind. They're helping them with financial aid, with hooking them up with programs for kids after school, for young mothers, for single parents. So there's much more information that's being shared in those situations on a very natural and a prescribed manner. But when you're talking about therapy, we don't give information like that. That's not what we do, at least not on a theoretical level, like it says here, that people were using, but they couldn't talk about it. It says that education was a component of many psychoanalytic techniques. It stemmed a bit from the wariness of imposing values. And as a logotherapist, I finished my diplomate in logotherapy in 2010, 2011, something like that. We learned that Socratic dialogue is the workhouse of logotherapy. Socratic dialogue is asking questions, is about being a midwife of finding the answers from within the client and not offering answers, and definitely not offering information. And psychoeducation seemed to fly in the face of that. And this is how I approached psychoeducation when I first met it about 3 years ago. So first of all, what is psychoeducation? We'll start with the definition. There are a number of definitions that I found online. The most comprehensive one I found was brought down in this article from Aman Shudari, but Anderson apparently was a pivotal figure in the development of psychoeducation programs. And he wrote that the term psychoeducation comprises systemic, didactic, psychotherapeutic interventions. So it's a combination. It's not one thing. It comes from a merging of different fields of systems theory, of educational theory, and of psychotherapy, which are adequate. And what is it used for? For informing patients and their relatives about the illness and its treatment. Okay, so here it already goes up one level. It's not working only with the client, but we're using the psychoeducation for work with the families as well. And that I found interesting because that was also a main part of the Navigate program, was people who are going through first-time psychosis. We need for them to have a strong support system. We need to work with their families. And we'll see a little bit of that a bit later. So, and it's facilitating both an understanding and being personally responsible, and a personally responsible handling of the illness, and supporting those afflicted in coping with the disorder. So psychoeducation is a tool that they viewed as valuable in helping the client himself and his support system in learning more about it and being able to go through it in a better way. So if we just look back a bit, the history of the term of psychoeducation, the first mention of education in psychotherapy was with Donnelly in 1911, and this first one may seem a bit dogmatic, and it's definitely not a logotherapeutic view of therapy, but he wrote that the fundamental purpose of all psychotherapy to bring about a cure of mind, okay, that's not so bad, by or through the mind, and seeks to explain the purpose that these methods subserve, that of re-education, which when I read that, it sounds a bit Orwellian. It's a bit hard for me to read that, but that's where it gets started. We talk about education in therapy, that we have certain information that is important for the client to know. 1941, the Psychoeducational Clinic is written by Brian Tomlinson. It's a book that describes how to build such a clinic that offers information to people who are going through psychological issues. By the 1940s, psychologists and psychological treatment is no longer a new thing. It's been around for 30, 40 years. And depending on who you ask, when modern psychological treatment actually started, but it's been around for a while, and they're starting to develop new concepts and seeing how we spread it even more. In 1980, this is 40 years later, we mentioned Anderson before, and he writes about the and this was the first major article that appeared in journals that really gave it a broad overview of psychoeducation. We talked about co-structured, supportive, psychoeducational, family interventions. Again, we're talking about the family here, not necessarily just the client, but the family, the support system, are aimed at de-intensifying the family environment in which the patient lives. So it's not just giving them the ability to help him, but for them to understand what he's going through, and they can rearrange their expectations of him, his behavior, how he talks, what he says, in a way that's more appropriate for what he's going through. Even 20 years later, it hadn't really quite caught on. To date, only those addressing schizophrenia and cancer can be considered evidence-based. People were still playing around with it. They were still trying to figure out, get their heads wrapped around what this idea is. Healthcare workers have become increasingly aware of the critical role that familial and other informal sources of support play. This is already 25 years after Anderson's article, and we see that they're starting to become aware of the critical role that familial and other informal sources play. We see that it takes time for this concept to come in, and I believe that it goes back to the first slide that we saw, that there was a general distrust of education in therapy. That's not what therapy is for. Therapy is for helping the client understand the answers for himself, to use Socratic dialogue to help him birth his own healing process. And now in 2023, another 20 years have passed, but we already see 13,000 hits on Google since 2000. Just in the last 4 years, in the Sage Journal's website, there were almost 5,000 hits for the term of psychoeducation. Raise and Navigate and other programs around the world are incorporating psychoeducation into their practice with varied populations. We see that it's becoming a tool that people are using more and more, and becoming more comfortable with the concept of introducing education into psychological treatment. Okay, the rationale, we've already started to touch on this. The patient or client and or the family are considered partners with the provider in treatment. The clinic works together with them. on the premise that the more knowledgeable the care recipients and informal caregivers are, the more positive health-related outcomes will be for all. If more people surrounding the person who's suffering have information about what the person is going through, the likelihood of them to live a healthier, more functioning life is greater. It's highly correlated. And this is around the same time as the second article that we saw after Anderson in 2004. What would be the goals of psychoeducation then? To ensure basic knowledge and competence of patients, and again, and their relatives. How important it is. It keeps on coming up over and over and over again, the importance of including the family in the treatment of certain psychological illnesses, and to give them the information about the illness, providing knowledge about various facets of illness, signs, symptoms, the course of the illness, the outcome, and the prognosis. Although prognosis is something I generally shy away from because we can only guess. We've all seen people who seem to be suffering from light symptoms, but they get worse, or they just drag on. And we've seen people who suffer from severe illnesses, and somehow they seem to just snap out of it. So a prognosis is something I generally stay away from. And I think Frankl also didn't usually give prognosis, except saying there's always a chance. We never give up on anyone, Frankl used to say. Another goal is helping people having the knowledge of do's and don'ts while rendering care, treatment options, side effects of medication, and other somatic treatments. We can't expect everybody to know all of the side effects of all of the medication. I personally stayed away from this because I'm not a medical professional. I don't like giving people information about drugs, even something as simple as aspirin or Acamol or Tylenol or anything along those lines, because I'm not a doctor and I don't understand, and I don't know how it affects the liver and the kidneys and other things in the body, other organs. So I generally stay away from side effects of medication. I always refer them to their doctor, the person who gave them the medication, to give the answer about what side effects it might be. I do offer another goal is to offer the ability to dispel myths, misconceptions, and unawareness. What do people already know about schizophrenia? What do they know about bipolar? What do they know about substance abuse or personality disorder? What have they heard? What have they seen on television? What movies do they know? Aside from A Beautiful Mind, what other movies do they know that talk about Flowers for Algernon with autism? What else? What do they know about this, and what do they think they know? And let that be on the table. Let's see. What tools do you have? What information do you have that can help or break the treatment? A major purpose here is to promote relapse prevention. When I see promote relapse, it took me 4 times to read through that. So it's to promote relapse prevention and to track early signs of the illness coming back. It's to deepen the patient's role as an expert and empower them. They know that they're not feeling well. It's not a surprise to them. They know that something is wrong. And they know that they're not functioning on the level that they'd like to function in. And this was one of the biggest surprises when I started working in mental health about 20 years ago. And I didn't understand. I came in and somebody said, well, what do you think of people suffering from mental illness? So I say they're irresponsible and they're a bit strange. And she said, this is what they think of themselves also. And they know that they can't always be relied on, and they know that they're suffering, and they know that some of the things that they do, whether it's OCD, they know what it looks like, and they know how people view them. So it's to deepen the patient's role as an expert. Okay, this is the information that you have. You should know what you're going through. You should know what to expect. And also to engage in crisis management and suicide prevention. People with mental illness have a higher rate of suicide than the general population. So the essential elements of psychoeducation are briefing the patients about their illness, problem-solving training to prevent stress buildup, and this also gives them empowerment in being able to solve problems. Communication training, instead of hiding things, to be able to communicate difficulties and understand what it is they're communicating and help other people to understand what they're communicating. Self-assertiveness training, and this already brings a bit of logotherapy. The belief in self, the belief in his uniqueness, the belief in his own worth and value. This is what Frankl talks about all the time, and this is also an essential element of psychoeducation to help a person to believe in themselves despite the fact that they're suffering. There are two kinds of psychoeducation. There's simple and there's protocol-based. The simple psychoeducation is every time we use a term or explain a diagnosis, we engage in psychoeducation. We tell someone that, okay, whether we give a diagnosis or whether they've gotten it from a psychiatrist and it says OCD, what does OCD mean? And we can engage then. And also going back and using these elements, using these goals to dispel myths, to be able to answer questions. So that's simple psychoeducation. There's also protocol psychoeducation, which is the one that I was introduced to when I started working with Navigate. So programs like Raise Navigate may use the prepared protocol for psychoeducation of clients with first episode psychosis and with their families. So here we'll just take a quick look at some of those protocols. Okay, can you see this on your screens? The clinical guidelines for education about psychosis. You see that?
Yes, works well.
Okay, very good. Okay, so this module may be done individually with the person and their family, or separately with the person and with their family. Then you present information to individuals to help them better understand the symptoms of their illness, how substance use interacts with psychosis, the medications used to treat schizophrenia, strategies to cope better with success, and strategies to build resilience. These are the exact elements that we saw before. The elements of, where is it? The elements of briefing them about their illness, problem solving, communication training, and self-assertiveness training. Okay, so that's the work with the client. So again, review and discuss the symptoms, provide information about the different kinds of psychoactive substances and their effects, about the medications, identify areas of stress and strategies to cope more effectively with these stressors, and review and discuss the benefits of resiliency and help the individual and identify resiliency stories within their life. Just a quick shout out to the book written by Stephen Southwick, RIP, that called Resilience, a logotherapist who walks through 11 different elements of resilience, help people overcome trauma, and he did this through his work with Marines and with people who went through 9/11 on a personal basis. Okay, that's the client's sheet that they get, and for the people working with the families, this, okay, clinical guidelines for just the facts. What is psychosis? What do we tell the families? The basic facts about psychosis and schizophrenia spectrum disorders. There are over 50 different kinds of schizophrenia. And very often the diagnosis just says schizophrenia, and very often it's one or another kind of it. So talk about the different disorders. You should begin by inquiring about what do they already know about psychosis. What is, this is the term that we might use at a conference, but people in the street will very often just say that person is crazy. It's not a term that we use, but this is what people say. What does that mean to people? What does it mean that it's in their house, in their family? Is it genetic? These are questions that come up. These are questions that the workers here are trained to answer. About halfway through the material, the link between psychosis and schizophrenia spectrum disorders is made more explicit. The causes of schizophrenia are presented, and stress vulnerability model is what, again, how to deal with stress. First episode, psychosis, is also discussed. How is it different from a second episode or a relapse? And again, the goals are to elicit information on their understanding of the symptoms, provide education that addresses gaps in their knowledge, and again, also introduces stress vulnerability, provide a message of hope and optimism by outlining the possibilities for treatment and recovery. And give handouts, and people are able to ask questions and be in touch with the team that's working, and each person gets a team that works with them, and they work on employment, they work on family support, and there's one person who works directly with the person suffering, and there's always a psychiatrist on the team as well. And with these four people, they all work together with the family, and they conduct regular meetings on a monthly or bi-monthly basis as time goes on in the treatment. And the thing you may want to know most about psychoeducation is efficacy. So family interventions, including psychoeducation for schizophrenia, have proved to be one of the most consistently effective treatment modalities available, with relapse rate reduction at 50 to 60% over treatment as usual. Okay, that doesn't mean that 50 or 60% of people are cured or prevents remission, prevents relapse, but over regular treatment, there's a growth of 50 to 60% of people whose rate of relapse is reduced. Besides relapse severity reduction, psychoeducation leads to less frequent relapses. When they finally do have a relapse, instead of it happening once every 6 to 12 months, it can happen once every 2 to 3 years, which for a family makes a huge difference in their ability to live a functioning life, a happy life, a family life. There's better treatment adherence when you're working together with psychoeducation. There's lower self-stigma. Self-stigma was one of the first terms I learned when I moved into working with mental health, about what people think of themselves when they know that they're suffering. Better quality of life, improvement of social competencies, active engagement in rehab, and lower cost of care, either alone or as part of complex treatment regimen. The same thing, we find that family psychoeducation with pharmacotherapy, psychoeducation also works with families with various types of psychiatric disorders. It can also help individuals in late emerging adulthood to develop a healthy perception of their identity. Populations who may be helped: people suffering from schizophrenia, bipolar, anxiety, depression, substance abuse, personality disorders, and dual diagnosis as well. Limitations: to date, as of 2004, to date, only those addressing schizophrenia cancer can be considered evidence-based. But in 2023, we already find a relatively rare blood disease called Beset, that the evaluation of the psychoeducation program provided to people living with Beset's disease in the context of the Roy adaptation model, increases the patient's compliance with the disease and reduced psychiatric symptoms. It doesn't work on everything. It did not change dyadic adjustment and self-esteem. Just a second. It is recommended that the spouses and relatives of patients be included in psychoeducation. They saw that there was a marked difference when families were included. The disclaimer is, again, it's not for everyone, just as with any technique, just as you wouldn't use paradoxical intention or Socratic dialogue with everyone, you would not use this, and we want to prevent iatrogenic damage. So that's where we leave off with psychoeducation. Lovely quote from Nelson Mandela: "Education is the most powerful weapon with which you can use to change the world." Any questions on psychoeducation until now? Okay, so I'll move ahead. Logotherapy principles. I'm going to kind of run through this because most of you know most of what's going to show up here. That Frankl started writing about the concepts of logotherapy in the 1920s, started writing Doctor on the Soul in the 30s. He wrote Man's Search for Meaning in the mid-40s after his experience in the Nazi death camps. He taught that the basic motivation of man is to find meaning in his life. He often quoted Nietzsche, who said, if a man has a why to live for, he may endure almost any suffering. I remember the day that one of the students pointed out the word almost. I hadn't noticed it. And they said it's almost, and it makes the sentence even more powerful for me. Okay, basic concepts. Again, we're not going to spend a lot of time here. Authenticity, a person has to live an authentic life. There's a concept that he borrowed from Kierkegaard. The will to meaning, that this is the basic motivation that we have, is to find meaning in life, and that gives us the healthy tension to move forward, to not stay where we are. And even when we achieve something, we wish to celebrate, we can celebrate, and then what's next? Take the time to celebrate. The challenge is to find, in therapy, the challenge is to find each other in a face-to-face encounter. We view the client as a partner in therapy, and not just as someone receiving. Again, we talked about Socratic dialogue as the workhorse of logotherapy, and therapists must be careful not to impose values, yet must have a value system. Okay, this goes again back to the issue with psychoeducation, whether it's imposing values or it's just sharing information. So where can psychoeducation fit in with logotherapy? It can help with concepts, with tools, and with understanding of pathology. Concepts that we can help teach people are freedom of will, responsibility, healthy tension, which we spoke about, and we'll get to it again in a moment, attitudinal modulation, how we deal with difficulty, and therapy as a meeting of two humans, which is something that we just saw that Taria Chantal spoke about as well. I'll just take this one as an example of healthy tension and uniqueness. We explain about each individual's uniqueness. Every man is indispensable and irreplaceable. This is such a basic concept that so many clients have a difficulty with. They come into the clinic not believing this, not believing that they're unique, not believing that they have a role, not believing that they're anything special or that they have anything to offer, not believing they have any self-worth. And to go back to this, and the cynics will say the cemetery is filled with people who are irreplaceable. And the answer to that is, it could be that their positions were replaceable, but the human being is not. No human being is actually replaceable. In the 30s, Frankl often heard from unemployed people that they were useless, that's what they felt, and therefore their lives were pointless. He did not hesitate to expose this remark. This is psychoeducation. He did not hesitate to expose this remark as a double misidentification, because it is simply incorrect. Unemployed people do not need to be useless. They can do a lot of useful things, writes Lucas about Frankl. We can use psychoeducation in tools, in Socratic dialogue. We can explain what it is, paradoxical intention, which we'll see in a moment. De-reflection, Elizabeth Lucas ran a de-reflection group, helping people find joy in their lives. And the very useful tool of Ecce Homo that Frankl mentions a little bit, and Taria Chantal expands on in her writings. So in paradoxical intention, Fabry writes that to prepare patients for paradoxical intention, the logotherapist instructs them how this method works. Gertz wrote this also, that the therapist explains to the patient the neurophysiological mechanism that maintains his neurosis on the one hand, but also helps him understand how he is to apply paradoxical intention. Frankl himself did not necessarily explain paradoxical intention. He would just use it, as we saw in a number of cases that he mentioned in his writings. So the choice is yours, but know that this is an option as well. In understanding of pathology, we can use psychoeducation when we share a diagnosis, a logotherapeutic diagnosis, and to stay away from iatrogenic damage. We offer a logo explanation. We explain existential vacuum, and we can teach people about logotherapy through the Frankl grid. The Frankl grid, for those of you who just need a quick refresher, there's a meaning axis, there's a success axis. Most everybody wants to be in this quadrant of joy and satisfaction. If we have a lot of meaning in our lives, but we don't feel that we're successful, there's a large sense of frustration. People who may be very successful, but don't have that sense of meaning, can experience existential vacuum. And the most difficult place where nobody wants to be is in a place where they feel that there is no meaning in their lives, nor do they feel that they are successful. And this can lead to despair, and in even worse cases, apathy. And because in apathy, it's a worst case in my eyes, because you don't feel anything anymore. In despair, at least you're still feeling something. At least you're feeling the suffering. I'm not happy that they're suffering, but I can appreciate that, and I can use that despair. Once a person experiences apathy, it's much harder to help them move from there. In Frankl's use of psychoeducation, another case that he writes about, when a fear of psychosis does occur, it is well to go into the problem quite matter-of-factly. We might call the patient's attention to the works of Pilch and Stengel, which suggest a certain antagonism between obsessional neuroses and psychotic illnesses. They don't happen together. People who get psychosis, says Frankl, will not get a neurotic illness, and which indicate that the obsessional neurotic, in spite of, or in fact because of his obsessional fears, seems to be all but immune to psychoses, and it's the other way around as well. So here we find Frankl himself using psychoeducation not as protocol, but actually it's a protocol in the cases of a fear of psychosis. I don't know, we have about 5 minutes left. I have 3 cases here. I'll jump to the third, because that's the most structured of the 3. And if we have time, we'll go back to one of the other 2. Hannah was a 53-year-old female married with children, basically functioning well, working. The presenting problem was her sense of melancholy about her family situation, empty nest syndrome, weakening of the spousal relationship. She agreed that we use learning of logotherapy as a form of therapy. Okay, so I'm not going to ask you all the questions that people usually ask, but we're going to learn logotherapy. And what we did was we studied the 3 pillars of logotherapy: the freedom of will, the unconditional meaning, and someone help me here?
Will to meaning.
Unconditional meaning, I'm sorry?
Will to meaning.
Will to meaning and freedom of will. Okay, there we go. So we use those 3 pillars of logotherapy and the 3 paths to meaning: the creative, the experiential, and the attitudinal. She found that she could notice more meaning in her life and was generally more happy. We used a protocol. We used a formal study of logotherapy. It was one-on-one, so there was a lot of discussion of these concepts. There were 6 sessions that we didn't know ahead of time how this would look, but within 6 sessions, we were able to work through the sense of melancholy that she had, and she looked happier. Her spousal relationship was improving, She changed jobs. She was in general a happier person. I wasn't really 100% convinced that this was working. So I called her up 2 months later and checked, and yeah, and the information that we studied together still held for her, and her mood was still upbeat and happy. Okay. Okay, so we'll go back to David. David was a 28-year-old male suffering from active schizophrenic psychosis. He was able to work in a supported employment environment, and his presenting problem was how to function better while suffering. First thing to do that we did was connect with the healthy part. And every schizophrenic has a healthy part. Every person suffering with schizophrenia has that 2 × 2 = 4, and that remains true even if a schizophrenic individual makes the statement, says Frankl. So know that healthy part is there. And the psychoeducation came into being or came into use where there was educating him about his ability to choose. Even if he was suffering from schizophrenia, he had the ability to choose. He could choose, and he had this invisible friend who was talking to him and telling him what projects he was supposed to be doing. And once he knew that he was able to choose, he was able to ask himself, are the projects that this friend is telling him to do they help him develop, or do they hold him back? And he learned to make choices, and eventually became a life coach, and he's married, has 2 kids. And this is how psychoeducation can help. It's a wonderful tool. It helps. It improve it. For me, I use it. Sometimes I only notice afterwards that I've used it, that I've explained something, and use it, and see people appreciate it. People appreciate when I explain the concepts of logotherapy to them, and we talk about them, and they understand them, and they internalize them, and they learn to use them in their daily lives. And we'll just get to the summary. If we have time to go back and look at Jonah as well, we'll do that. But I want to stick by the time. The summary is we saw what psychoeducation is and how it helps. We reviewed some basic principles of logotherapy, and saw how psychoeducation can, and in my opinion, ought to be a part of logotherapy clinical practice in explaining concepts, techniques, or diagnoses. Okay, thank you very much. Okay, any questions, comments? Okay, Darren, I see that your hand is up. No, okay. Yes,
Dr. Friedman, I just wanted to say thank you for bringing this. You hear me, right?
Yeah.
For bringing this psychoeducation piece in, because in training as a counselor, there's kind of an animosity against it, don't do that psychoeducation. So this is helpful and supportive of, yeah, there are teaching moments, and it has its place, and it's useful. So thank you.
You're very welcome. You're welcome, Maria. Have any of you ever used it? Consciously or unconsciously? So I find myself sometimes just slipping into it. It's already half past, so if people want to move on to the next session or get themselves a cup of coffee before the next session, that's okay. You're very welcome, Elaine. Have any of you used psychoeducation, either on purpose or by accident? Yes, Maria. Can you just share a little bit of that? Okay, I still can't hear you. Ishan? Ishan, can you help with this, please?